What's up, everyone? It's Miles here from bootcamp.com, and today in pulmonology, we're going to be going over perfusion versus diffusion. So first, let's go over a few basic principles, starting with gas equilibration. So equilibration basically means if we have a permeable membrane and we have different concentrations of a substance on either side of the membrane, what's going to happen during equilibration is there's going to be movement of the substance across the membrane until there's going to be an equal amount of the substance on either side of the membrane. And so after equilibration, both sides are going to have equal amounts of substance. And in the case of gas equilibration in the lungs, let's say we're talking about oxygen. Oxygen enters the pulmonary capillaries at a partial pressure of 40 millimeters of mercury. And the alveolar partial pressure of oxygen is going to be 100 millimeters of mercury. And so as the blood moves through the pulmonary capillaries, equilibration is going to occur between the alveolar oxygen and the blood oxygen. And after the equilibration has occurred, the partial pressure of oxygen in the blood is going to be the same as the partial pressure of oxygen in the alveoli. So it's going to rise up to 100 millimeters of mercury. And then as the blood leaves the pulmonary capillaries and enters the arterial system, the partial pressure of oxygen in the arterial system is now going to be 100 millimeters of mercury. And so by the time the blood reaches the end of the pulmonary capillary, the blood gas pressures are going to equal the alveolar gas pressures. And one other important concept is that we have hemoglobin floating in the blood. And when a gas binds to hemoglobin, such as oxygen, once it's bound to hemoglobin, it no longer exerts a partial pressure. The only time a gas will exert a partial pressure in the blood is when it's a freely dissolved gas, not bound to anything. And so gas bound to hemoglobin doesn't contribute to gas pressures in the blood. And so when we're talking about the equilibration of gas pressures across the alveolar capillary membrane, any gas that's bound to hemoglobin in the blood essentially doesn't count. So we might have way more oxygen in the blood than in the alveoli, but in the blood, most of that oxygen is bound up by hemoglobin, and so it doesn't exert a partial pressure. And so the partial pressure might actually be lower in the blood than in the alveoli. And if the partial pressure of oxygen is higher in the alveoli than in the blood, then there's going to be a net movement of oxygen into the blood until both of the partial pressures of oxygen in the alveoli and in the blood are equal. So now we're going to be talking about perfusion limited versus diffusion limited gases. So remember that perfusion essentially means the blood flow to an area or the blood supply to an area, and in this case we're going to be talking about the blood flow to the alveoli, whereas diffusion is essentially referring to the gas exchange across the alveolar capillary membrane. So first we're going to start off by talking about perfusion limited gases. So for a perfusion limited gas, the rate of gas uptake into the blood from the alveoli is mostly affected by the blood flow to the alveoli. And a classic example of a perfusion limited gas is nitrous oxide, or N2O. And so if we just take a look at our diagram to the right here, we start with nitrous oxide and it diffuses into the blood. And when it diffuses into the blood, it doesn't really bind to hemoglobin, and we mostly just find it in the freely dissolved form. And because it's going to be found in the freely dissolved form, it starts to exert a partial pressure right away. And because the nitrous oxide that is diffusing into the blood starts to build up a partial pressure in the blood very quickly, that means the equilibration between the partial pressure of nitrous oxide in the alveoli and in the blood is also going to occur fairly quickly. And so we have that right here. The nitrous oxide doesn't bind to hemoglobin, and as a result, it saturates the blood very quickly, or it builds up a partial pressure in the blood very quickly. And as a result of this, it's going to equilibrate with the alveolar partial pressure very quickly as well. And that's one of the hallmarks of a gas that is perfusion limited. It's that the gas in the blood is always going to reach equilibrium with the alveolar pressure. And so if we just take a look at this graph here, we have the length along the pulmonary capillary on the x-axis, and we're going to have partial pressure of a gas on the y-axis. And we have this line up here, which represents the partial pressure of that gas in the alveoli. And when we plot our nitrous oxide curve here, we can see that at the beginning of the pulmonary capillaries here, the partial pressure of nitrous oxide is going to be 0, and that's because we don't usually find nitrous oxide in the blood. This is through some sort of nitrous oxide inhalation test. And we can see that very quickly, the partial pressure of nitrous oxide in the blood is going to be equal to the partial pressure of nitrous oxide in the alveoli, or in other words, the partial partial pressure of nitrous oxide in the blood is going to very quickly equilibrate with the partial pressure of nitrous oxide in the alveoli. Another gas that's going to be perfusion limited is going to be oxygen in healthy lungs. And so oxygen is similar to nitrous oxide in that they both reach equilibration with alveolar pressures. However, oxygen differs from nitrous oxide because oxygen actually takes longer to reach that equilibration. So because nitrous oxide builds up that partial pressure so quickly, it's going to equilibrate very early on in the pulmonary capillaries. Whereas it actually takes longer for oxygen to build up partial pressure in the blood, and so it's not going to reach equilibration until later on in the pulmonary capillaries. And the reason that it takes longer for oxygen to build up partial pressure in the blood is because of hemoglobin. So when oxygen diffuses from the alveoli into the blood, some of it is going to be freely dissolved and start to exert a partial pressure. However, some of it is going to get bound up by hemoglobin, which does not exert a partial pressure. And so because oxygen binds to hemoglobin in the blood, in addition to building up partial pressure as a freely dissolved gas, we're going to have to move in more oxygen into the blood until it builds up enough partial pressure to equal the alveolar pressure. And so if we just take a look at the oxygen curve on our graph here, we can see that the oxygen is coming in from the venous system at 40 millimeters of mercury. And so like nitrous oxide, we can see that oxygen eventually does reach equilibration with the alveolar pressures. However, this process takes longer than nitrous oxide, and that's because the oxygen that's being bound to hemoglobin is delaying the speed at which we're building up partial pressure in the blood, and so it's going to take longer to build up the same partial pressure in the blood as the alveoli. And so like we mentioned, for gases that are perfusion limited, the way to increase uptake of that gas into the blood is going to be to increase blood flow, like in this diagram shown right here. So like in the case of nitrous oxide, it reaches equilibration very early on in the pulmonary capillary. And for the rest of the length of the pulmonary capillary, after equilibration has occurred, there's going to be no more net movement of gas into the blood. However, if we increase blood flow to the alveoli, there's going to be more blood available for the gas to equilibrate into. And as a result, the gas may not reach equilibration until later on in the pulmonary capillary, and that's because we need to uptake more gas into the blood before equilibration has occurred between the increased blood volume and the alveoli. Okay, so the next thing that we're going to talk about is diffusion limited gases. So for a diffusion limited gas, the gas uptake into the blood from the alveoli is mostly affected by the diffusion capacity of the lungs, or in other words, how intact the alveolar capillary membrane is. And the classic diffusion limited gas is carbon monoxide. And so if we just take a look at the diagram to the right here, when we have carbon monoxide in the alveoli, when it diffuses into the blood, it has a really high affinity for hemoglobin, and virtually all of the carbon monoxide in the blood is going to get bound up by hemoglobin. And because all of the carbon monoxide is being bound up by hemoglobin and we're not really seeing it as a freely dissolved gas, carbon monoxide barely builds up at partial pressure in the blood. And so we have that here. Carbon monoxide binds with really high affinity to hemoglobin, and as a result, it barely builds up any partial pressures in the blood. And because it doesn't really build up a partial pressure in the blood, the carbon monoxide partial pressure in the alveoli is never really going to equilibrate with the partial pressure of carbon monoxide in the blood. And that's a hallmark of diffusion limited gases. The partial pressure of the gas in the blood never equilibrates with the alveolar pressure. And so if we just add in our carbon monoxide curve here, we can see here that even at the end of the pulmonary capillary, the partial pressure of carbon monoxide in the blood is not going to reach the partial pressure of carbon monoxide found in the alveoli. And because the partial pressure of carbon monoxide in the alveoli is always going to be higher than that in the blood, there's always going to be a pressure gradient for carbon monoxide to move from the alveoli into the blood. Another diffusion limited gas could also be oxygen in disease lungs that have diffusion defects. And a classic example of this is pulmonary fibrosis, where we have increased alveolar membrane thickness due to the deposition of fibrous tissue in the alveolar capillary membrane. And so if we just take a look at our diagram to the right here, we said that under normal conditions, oxygen will reach equilibrium between the blood and the alveoli. However, it happens a little bit later in the pulmonary capillaries. However, if we have the deposition of fibrous tissue in the alveolar capillary membrane, then this is going to impair gas exchange such that blood that is flowing through the pulmonary capillaries may not actually ever reach equilibration with pressures in the alveoli. So if we just take a look at our graph again and we see the oxygen curve in pulmonary fibrosis, we can see that again oxygen is entering the pulmonary capillaries at 40 millimeters of mercury, but since gas exchange is impaired in this example, we're never actually reaching equilibrium between the blood and the alveoli. Alright, so now we're going to finish off by talking about something called the diffusion capacity of the lungs of carbon monoxide, also known as DLCO. So because carbon monoxide is completely diffusion limited, we can use it to measure the diffusion capacity of the lungs. And so what we do is we ask the patient to inhale a certain amount of carbon monoxide, and then we measure the amount of carbon monoxide in their exhaled air, and that amount should decrease because some of the carbon monoxide should have diffused into the blood. And this measurement is called DLCO, and we're going to see that in certain pathologies, certain lungs are going to permit less carbon monoxide diffusion into the blood than normal. And these conditions are called low DLCO disorders, such as these conditions right here. And so the DLCO is going to be decreased in pulmonary fibrosis, and like we said, that's due to increased alveolar membrane thickness, so the carbon monoxide is going to have a hard time diffusing from the alveoli across that thick fibrotic membrane and then into the blood, and so there's going to be less carbon monoxide diffusion into the blood compared to normal. The DLCO is also going to be decreased in emphysema. Remember that in emphysema we have the destruction of alveoli, and so we're going to have less surface area available for gas to diffuse into the blood, or in other words, we're going to have less gas exchanging surfaces. And so because we have less gas exchanging surfaces available, when we inhale the carbon monoxide, there's going to be less surface area available for that carbon monoxide to move into the blood. And so as a result, there's going to be decreased uptake of carbon monoxide into the blood. All right, and that's all we got for our video on perfusion versus diffusion.